Okay, good evening, everybody. Welcome to this eighth session of 52nd Comprehensive Course on Echocardiography. Last time we read about mitral stenosis and tricuspid stenosis. Moving on further, let's listen about valvular stenotic lesions, that's aortic stenosis and pulmonic stenosis. Well, this is the 52nd course which we are running. We started somewhere in April 2000 and we started this program on 27 September 2025. I'm Dr. Rakesh Gupta from Drop Institute of Echocardiography, Ultrasound and Vascular Doctor, and we are going to talk about the most important topic is aortic stenosis and pulmonic stenosis today. Let's move on to my slide presentation. I hope all of you can see the slides. If that is correct, anybody can raise his hand so that I'm able to understand that everybody is able to see the slides. All right. So Dr. Neeraj, 44 number, he said, yes, we are able to see the slides. Well, the aortic stenosis is a very important modality. Why? In the sense, if we diagnose it correctly at a proper time, the outcome is very good. So we have to decide how to assess aortic stenosis. Before that, what is the need of assessing aortic stenosis? What are the pitfalls? What are the concomitant lesions and interventions causes? We are not going to talk about the intervention causes and other things, but certainly we need to say why we need to assess aortic stenosis. Look at this slide very carefully. The person who has got a severe aortic stenosis, his follow-up was seen till the age of almost 5 years, 60 months. And the person is almost asymptomatic. Once he develops the symptoms, whether it's angina, syncope, or a failure is not going to talk about failure. Failure means dyspnea. When you talk of effort angina, effort syncope, and dyspnea, then the cumulative graph of survival drops down dramatically. If you look carefully, it's with 60 months over here, between 60 to 65 months of diagnosing aortic stenosis with symptomatology, the fall is very dramatic. Means to say that every year we are losing about every month we are losing about 5 to 10% of the subjects. So that's what is important. And that's why it's important to look for aortic stenosis. Just yesterday, there was a patient who came with loss of consciousness, syncope, and he was having a bicuspid aortic valve for a long time. When we did his echo, the peak gradients was more than 54. Mean gradients were 54. Peak velocity was more than 4.7. Aortic valve area was less than 0.80 centimeters square, aptly getting classified into severe aortic stenosis. And the first symptom happened only a few days back, that is syncope. And when we talk to the patient, look, now you need surgery. He says, sir, I'm absolutely asymptomatic. Nothing has happened to me except for one syncopal attack. And it's very difficult to convince a person that one syncopal attack means surgery. But that is true because look at the natural history of these subjects. And this slide is not from today. This slide is almost for last 20 years. Same is velocity. If the velocity is more than 4 meters per second, follow them after 5 years, whether symptomatic or asymptomatic, their survival becomes less and less. In comparison, velocity is less than 3 meters per second versus more than 4 meters per second. So need to say that the gradients as well as the symptoms makes a lot of difference. And this is based on New York Heart Association classification 1, 2, and 3. The more the patient is symptomatic, the poorer is the survival. So question is how to assess the severity, how to assess LV function, evaluation of aorta, surgical timings, and complications. Very busy slide, but believe my word, slide was created in year 2002. It was created by Mayo Clinic, Rochester. And this slide is valid even today also. What does it tell you? It talks about two dimensions Doppler data. 2D echo plus Doppler data. And what are these dimensions? Two dimensions echo means morphology of the valve. Doppler means gradient, cardiac output, and aortic valve area. If they are adequate, you have made the diagnosis. I'll come to this part later on. So let me talk of two dimensions data and a Doppler data to come to a morphology, gradient, cardiac output, and aortic valve area to make a complete diagnosis. Let's look at M mode. Well, if you look at an M mode of these people, their opening gets smaller and smaller. How do you put an M mode? You put an M mode, a cursor line across the aortic valve leaflets over here. All right. So this is a plaques view, and this is the Doppler line which is cutting across aortic valve leaflet, and you get this M mode where the aortic valve opening is seen over here, right cornicus, non-cornicus, and the closing is seen over here. This opening has to be between 15 to 26 millimeter in size. Smaller the opening, the possible chances are we are dealing with aortic valve stenosis. Second is closer line. Normally this is opening, so closer line is central in tricuspid aortic valve. It is eccentric in bicuspid aortic valve. So that's how we see in M mode, although we do not depend much on M mode today. I'm just showing you for the sake of history. Otherwise, we are not dependent on this M mode. What we need to look at is doming in systole. Look at this valve. It's domes in systole. Let me try to hold this picture if I'm able to do it. So whenever this picture holds up, now look, this is doming of the valve. And whenever the doming of the valve happens, you find turbulence across this particular valve. Somebody asked me a very good question last time. When we are perpendicular, still we are seeing so much of a turbulence we do not expect. My answer was, despite being perpendicular, we have so much of turbulence means the valve is really stenotic or regurgitate. Now this is a zoomed up view. Let's focus. I'm not going to go very fast on this aortic stenosis. Now look at carefully. Doming means like something when it opens up is not able to adequately open up. And that is what is known as doming. The same thing what Dr. Prasha told you last time, that doming of the mitral valve leaflet was suggestive of mitral stenosis. So here is a patient with a dilated aortic root, severe aortic regurgitation, and the flow velocity across the valve is significantly increased. Now the question is, what kind of the valve we see? we see a stenosis of the valves at the level of valves. That is known as valvular stenotic levels. That is at the level of valves. If it's above the valves, which is known as supravalvular. If it's below the valve, which is known as subvalvular lesions. So the lesion is valvular lesion in this patient. Now, this patient is a static slide. Look, this is a patient who has got aortic valve, but there's a subaortic membrane which is present over here, which is causing stenosis. So this patient has got aortic stenosis, but this is not truly a valvular aortic stenosis, it's subaortic stenosis. Similarly, here is a valve. Here is a supravalvular stenosis. There is obstruction distally, distal to the valve, which is known as supravalvular stenosis. Same thing, supravalvular stenosis, valve is over here, blockage is over here. And this factor cannot be seen by any other modality but two dimensions echo. Now look at this patient very carefully. Here is a supravalvular, above the valves. This is stenotic level above the valves. This is known as supravalvular stenosis. Now, once you come to a short axis view, we happen to see three leaflets of the aortic valve. It could be bicuspid. It means right-hand side leaflets. This is right-hand side leaflets. This bicuspid valve could be in this fashion also. And then it could be a unicuspid leaflet. So it could be right side, it could be left side, or it could be unicuspid. That could be a possibility. The third variety is we have horizontal aortic valve leaflets. So this is bicuspid. Look carefully. I'll try to stop the films for you. And it is seen not during playing. This is seen during opening phase. Look, the valve leaflet is one over here, second over here. And now see when the image is moving. So, and how do we get it? We are getting in parasol short axis view at aorta. So you have to make big P-sax aorta in every subject. Now this is a patient which picked up from a cath lab. Newborn, severe aortic stenosis, and you see this is pulmonic valve over here, this is aortic valve. And you can see just simple opening of this leaflets. There's only one like rounded structure is seen. Compare with this. So this is unicuspid aortic valve leaflet. You must be asking what we were doing in the cath lab with this patient. Patient was severely stenotic. So what we did a balloon dilatation of this aortic valve. Now how to assess it? Very simple, another slide from Mayo Clinic, Rochester. It says that whatever the blood which flows through the LVOT has to flow through the aortic valve. So how do you get the stroke volume across LVOT? We taught you earlier. LVOT diameter divided by 2 will give you radius. Radius square multiplied by pi will give you the stroke volume at the level of LVOT. And this is done by two measurements. One measurement is LVOT diameter. Second measurement is this LVOT diameter is always in Planck's view. LVOT VTI would be in 3-chamber or 5-chamber view just before the aortic valve leaflet. And that question was asked by many people, why somebody says LVOT should be 3 to 5 millimeter inside from the annulus. And that is the reason when we have a flow across the aortic valve, which is stenotic, a lot of turbulence happens at the level of annulus. To avoid the turbulence, we are 2 to 5 millimeter away. Otherwise, we will be overestimating our LVOT gradients, LVOT VTI. So the formula is area of the LVOT, that's what we are getting by radius divided by 2. Then aortic valve, LVOT VTI. So whatever the stroke volume over here is, it has to cross through the aortic valve. In aortic stenosis or in normal subject, this LVOT is derived by a pulse wave Doppler. When we switch over to continuous wave Doppler, it measures both across aortic valve as well as LVOT. So at take-home messages, LVOT diameter and LVOT VTI by pulse Doppler, then switch over to continuous wave Doppler in the same view to get aortic valve VTI. So what is left? That left is aortic valve area. So if we are calculating this divided by this denominator of aortic valve VTI, sorry, not this, aortic valve VTI, what is left behind is aortic valve area by continuity equations. I hope you are able to understand this concept, which is very, very important for any aortic stenosis. Why this concept is important? Because when we talk of mitral stenosis, we always say that we have to do planimetry. When we talk of aortic stenosis, we always say that we need to calculate continuity equations by area. And I'll explain you why this area is important. So, what is the LVOT, VTI, and diameter? Then we get a stroke volume. Stroke volume divided by aortic valve VTI, we get aortic valve area. Now, this is pictorial diagram. What is a pictorial diagram is? I'm getting LVOT VTI from the plaques view. Correct? Then I'm going to three-chamber view to look for LVOT across aortic valve VTI to see how much is the VTI of the aortic valve. And this is what we trace it to get aortic valve VTI. Then we keep a sample volume at the level of LVOT to drive LVOT VTI. And this diameter radius square into LVOT VTI will give you stroke volume divided by this VTI of the aortic valve. Now let's see, I'm starting measuring it. I have not measured at the level of 2 to 5 millimeter inside. I'm measuring at the level of annulus. My measurement is, what is my measurement? My measurement is, must be seen over here. It's about 2 centimeters square. 1.65. So this is 1.65 centimeters. So anybody can pick up a, yeah, it's here, LVOT dia 1.65 centimeters. Correct? Then we went on to do a LVOT VTI. In the same picture, like, look, this is three-chamber view. I can, allow me a second, I can make it bigger for you. Now, look at this. I'm just before the turbulence, before the aortic valve level to drive this LVOT VTI. Now, anybody has got a computer, a calculator, raise your hand and let's calculate what is my stroke volume is. So let's see who's raised his hand. So nobody has got a calculator. The calculator is there in your mobile phones. Yes, Dr. Patidar. Good, Dr. Patidar. Let's go ahead and calculate what is my stroke volume. How will you calculate? 1.65 divided by 2. So I'll also calculate along with you. You can open up your mic, Dr. Patidar, and then we can discuss at the same time in presence of everybody.
It's 0.825.
1.65 divided by 2 is 0.825.
825.
Now
Yes, sir.
I want to make a square of it. So I'll multiply this by what? I'll multiply with the same number,
Same number.
0.825.
Yes, sir.
Make it radial square. Now everybody understand whatever we calculated was diameter. Diameter divided by 2 will give you radius. Radius square is 0.825 into 0.825 is equal to 0.68. Correct?
Yes, sir. 0.68.
Now we'll multiply by what? Pi. Pi is 3.14.
It's 2.13.
It's 2.13 what?
1352. Sorry.
Correct. So we got an area that is 2.13. Now we add or multiply by radius. VTI. What is my VTI? 22.99.
22.99. Yes.
Correct?
Yes, sir.
22.99. So what is the volume now? 49 ml. Correct?
Yes, sir.
This is my stroke volume across LVOT. Is everybody clear? Okay. Let's move to the next slide. In this next slide is I calculate and went use my continuity equation to cover aortic stenosis, and I got a Doppler flow pattern which I traced it. And we have taught you already, once we trace it, we get peak velocity, peak gradient, mean gradient, and velocity time integral. So what I'm going to do is, I've got VTI across aortic valve, so I'm going to divide this 49.133 divided by 58.1. Is that correct? Dr. Chandra's particle?
Yes, sir. Yes, sir.
So what we are going to get is, what we are
0.
going
0.8456.
0.845 centimeter square is the aortic valve area. So 49 ml was a stroke volume. We divided 49 by 58, that is aortic valve VTI, to get stroke aortic valve area is 0.845. Is everybody clear? And when we talk of aortic valve area, we always talk of index. Suppose my body surface area is 2.5. His body surface area is only 1.7. How can be the same aortic valve could be present? Answer is indexed aortic valve area should be calculated, and this is indexed aortic valve area divided by body surface is 0.497. Are we clear now? And apart from that, when we calculated this flow across aortic valve, what we are getting over here? Look at, we are getting over here 2.95 peak velocity, mean velocity, peak gradient, mean gradient. Look, this patient has got a severe aortic stenosis, less than 1 centimeter square is our body valve area, but his gradients are low. And why these gradients are low? This person could be of those category which belongs to low flow, normal flow, anything more than 35 cc per meter square area of a stroke volume. I'll come to that later on. But gradients are low because what exactly happens over a period of time, the left ventricle, which is continuously pumping against obstruction, starts failing. So once we have to look at this, this looked innocuous in the sense we were not really sure that whether we are dealing with severe aortic stenosis or not, because of the factor that our aortic valve area is less than 1 centimeter square, but my gradients are low. And this is all what you require in day-to-day practice. What you need to look at is what in severe aortic stenosis is. You need to look at LVOT diameter. Calculate as many number of times as possible. Then you have to calculate LVOT, VTI, and then you have to calculate aortic valve area to get, then you have to calculate aortic valve flow to get peak and mean velocity and the gradients and aortic valve VTI. Now the other problem comes in this patients are, my valve leaflet is tri-leaflet valves, correct? And whenever they become stenotic, the jet could be in any direction. Suppose this valve becomes taken over here, they join together, only this hole is left behind. I do not know whether jet is going in any direction. So to look at the assessment of these jet, we have to look in 6 different windows. What are those windows? We start with apical window, 5-chamber view, then 3-chamber view, subcostal window, right parietal window, suprasternal window, and drop has decided or dried another windows, which is called as right anterior oblique. And wherever the maximum gradient is seen, not the average, wherever the maximum gradient is seen, we always say that the gradient is seen in this particular window. The person who I was talking about, he had a peak velocity and a gradient in right parasternal window, and unfortunately, nobody has seen that before. So we had to look. Everybody knows about 5-chamber, 3-chamber, subcostal, right parasternal, and suprasternal window. We'll demonstrate what is right anterior oblique view when we show a live demonstration. If you happen to do this much, I think we are done with our basic work of aortic stenosis. Before than that, another factor which is important is, what is the factor is? Driving force from the LV. This ejection fraction has to be normal to say that patient has got a significant gradient. Now come to a conclusion. My valve is pushing blood through aortic valve, correct? It is being pushed from a force which is being driven by LV. So if the LV function is normal, it will give you a proper gradients. And if the LV function is poor, the gradients would be low. So if I add one more thing to your calculation is LVOT diameter, LVOT VTI, aortic valve gradients and aortic valve VTI plus ejection fraction to drive to a category of aortic stenosis. And this has to be seen in all three chamber views, 4-chamber, 2-chamber, and 3-chamber. And you have to calculate ejection fraction by biplane Simpson's modified Simpson ejection fractions. Next comes when we calculated stroke volume, which we said was 49, we divide this stroke volume by a body surface area. Suppose this patient's body surface area is 1.7. So what will be my stroke volume? Index stroke volume. My index stroke volume would be, let's calculate, 49. I'll do it right in front of you. It's nothing wrong about it. So stroke volume is 49 ml divided by 49 ml slash 1.70 centimeter square is equal to, let's calculate what is the stroke volume, 49 ml. Dr. Chandra,
28.
yeah,
Yes,
how much?
28. 28.
28 ml,
8.
correct? So we call this as 28 ml per meter square area. And this is known as indexed stroke volume, correct? Now we learned LVOT VTI, we learned LVOT area. From this, we calculated stroke volume divided by body surface area. It gave us index stroke volume. From that LVOT stroke volume, if you divide by aortic valve stroke volume, aortic valve VTI, what you are getting is aortic valve area. And then ejection fractions. Don't look at these slides, they're not meant for you. So what you need to calculate is, you need to calculate index stroke volume, aortic valve area by continuity equation, then dimensionless index. This is one thing which is, it has recently come up to a large extent. Dimensional index means LVOT VTI divided by aortic valve VTI. Let me write down for you because then you will be able to remember correctly. LVOT VTI divided by aortic valve VTI. What does it mean by? It says that let's aortic valve, forget about aortic valve areas. Just look at the flow. VTI across LVOT versus VTI across aortic valve. If the ratio is less than 0.25, we consider it as severe aortic stenosis. All right. So I'm back to my equation, continuity equation, LVOT flow, LVOT VTI divided by aortic valve VTI, we are getting aortic valve area. Now I'm sure whatever the slide I showed you in the beginning, now we are back to the same slide. That's morphology, gradients, cardiac output. How do we calculate cardiac output? Is stroke volume into heart rate. Then aortic valve area. And if these are adequate, we are making a diagnosis of severe aortic stenosis. So what is the definition for a severe aortic stenosis? Aortic valve area less than 1 centimeter square, index less than 0.6 centimeter square, peak velocity more than 4 meters per second, mean gradient more than 40, stroke volume more than 35 cc, and normal ejection fraction, dimensionless index less than 0.25. Any doubt from anybody from this point of view? All right. Once we have done this, now the question, one more before I go further. We have to look at peak velocity across aortic valve by continued Doppler in all 6 windows, not only in one. Then next important thing is we classify them as variety of aortic stenosis. Why I'm touching this topic, although not at your level, is look, the most important thing is two important things. Aortic valve area is less than 1, less than 1, less than 1, less than 1 centimeter square. This is known as normal flow, normal gradient. Normal flow means more than 35 cc, more than 4 meters of a gradient and 40 millimeters of mean gradient. So normal flow is stroke indexed volume. Normal gradient is this. Now what exactly happens? This heart starts failing now. It goes to next stage of normal flow low gradients. What exactly happens? Aortic area calculation remains the same. Stroke volume also remains the same. But the gradients start falling down. The next is now my heart still starts failing down. What exactly happens? It moves from normal flow to low flow, low gradient, severe aortic stenosis, which is sometimes called as paradoxical aortic stenosis. And LV function is still normal in this subset of populations. It's a very unfortunate, like when we talk of aortic stenosis, we talk of ejection fraction as 52 in males and 54 in females. But if you look at the core of your thinking, if somebody has got aortic stenosis, the only important thing is they have a LVH. And whenever you have LVH, your ejection fraction will become super normal. They'll go to 67, 68, 9, 70% ejection fraction. By the time heart starts failing, what we take is normal ejection fraction is 54, 52. But that ejection fraction, nobody says that ejection fraction has come from 70 to 54. It means my heart has started working less. Now my flow may be maintained as in this person with a normal ejection fraction, or my flow becomes normal and gradient starts falling, and finally even the gradients across this starts falling down. But continuity equation area remains the same, less than 1 centimeter square. LV function is normal. So this is stage 1, stage 2, stage 3, not classified in literature. That's what I'm trying to say, stage 1, stage 2, stage 3. But it's a continuum of a disease from a high flow, high gradient, normal flow, normal gradient to normal flow, low gradient, low flow to low gradient. And then the fourth stage is when the even LV function starts going down, which is known as low flow, low gradient, severe aortic stenosis, the poor LV systolic function. And now you can understand why the calculation of aortic valve area is very important, why the calculation of a gradient is very important, why to calculate the stroke volume index is very important. And even if we try to miss all these things, one simple mistake of not doing a calculation of aortic valve area may land up a patient of severe aortic stenosis of low flow, low gradient paroxysmal aortic stenosis as progressive aortic stenosis. Because when we talk of aortic stenosis, we say that aortic valve area less than 1 is severe or more than 1 is progressive aortic stenosis. The whole thing revolves around aortic valve area. I'm not going to go much details in this subject. This is a very high profile subject. Believe my words, if I get an aortic valve stenosis, it takes me about 35 to 45 minutes to calculate my aortic valve evaluations. Many of you can jump and say, sir, why can't we do a planimetry in this subset of population? Well, it's a very good question if somebody has thought about it, not asked. What we realized over a period of time when we were doing a planimetry of these people have opened aortic valve did not correlate well with the cath data. However, when we did in transesophageal echo, we were able to get a very good cath data, equal cath data in transesophageal. Now look at this patient with a very good imaging quality. But the problem is this patient does not have aortic stenosis. We can really see all the cusp of the aortic valve leaflet. Here is 1, here is 2, here is 3. So only in cases where we have data by planimetry in transesophageal, now it's calculated 5.3 centimeters square. I often say these words when somebody comes to me like, what is my aortic valve area, aortic valve stenosis varieties? I said, hell with everything. Let's put a transesophageal probe inside and see what is my area is. Because what exactly important is my area? If my area is less than 1 centimeter square, why am I bothered for about all the gradients? But the problem is this is semi-invasive test. And that's what makes a difference when we look for a severe aortic stenosis. So I hope I'm able to give you an answer. And before moving to question answer sessions, I just need you to look at certain discrepancy which can happen in these subset of populations. Let me go back to the slide of Mayo Clinic Rochester. Because we are novice, take my words. We are absolutely novice. And this is one place, if you do not understand anything, or if you suppose you miss anything, then take a help of your seniors. What is my take home another message is, suppose I'm not able to get a correct answer of this. It could be inadequate Doppler data. There could be a lot of discrepancy. There's low cardiac output. What we need to do is we need to do a transesophageal echo. We may do a Doberman echo. We do a cardiac cath to look for the mean gradients. And recently we have added 2 more modalities, that is GLS and calcium scorings. So your level is level 1 when we look at all these parameters of aortic stenosis. And multiple things will happen where things is not good. If you have a coexisting AR, so AS plus AR, it may overestimate your Doppler data. Subaortic membrane is a different ballgame. Sometimes we catch up by continuously Doppler, MR jet. High output state, more flow, doubtful. Then post PVR assessment, obviously the post PVR is almost a forceful beat. And then atrial fibrillation, all of us knows we have a variable Doppler spectrum pattern in atrial fibrillations. So we have to look at all these things in consensus, but the basic of echocardiography in aortic stenosis are these factors which I've told you a few minutes back. All right. And a lot of data like is an important thing. Like I don't say like we will be able to do everything every day. But we need to look at this data. When we do this data, then we understand then more is left in these subset of populations. So I'll stop it over here. So many things are there, but let's talk about what we have learned, and I'll stop sharing my slides, come back at any time and take your questions at any time. So let's raise your hand. Let's classify, or let's listen what you want to say about your aortic stenosis. And be frank. I'll be able to answer you as many times as possible. I'm not hesitant. I'm not in a hurry at all. So anybody would like to ask questions, just raise your hand and then I'll call your name and then you can ask the questions. Don't tell me everybody is satisfied with aortic stenosis. I started doing echo in 86, 14 plus 26. 40 years, I'm not satisfied with aortic stenosis even today also. And you people can become satisfied in 40 minutes, does not look like that. All right. Rule number, hands-on session, rule number 6. Go ahead. What's your name? Unmute. Yeah, please go ahead.
Rajan Verma.
Your voice is cracking down.
Hello.
Yeah, go ahead. Now I can hear you.
Sir, my name is Rajan Verma.
Rajan,
Rajan Verma.
6 number, right?
Sir, I want to please clarify about, sir, dimensionless index, sir.
Dimensionless index,
Yes, sir,
Rajan,
6
is
number.
very simple. Let me go and show you the slides. What is dimensionless indexes? So I'm going to shorten it down. Can you take a calculator along with you?
Yes, sir.
All right. This is LVOT VTI. What is the LVOT VTI in this patient?
Sir, 22.99.
Perfect. So 22.99 divided by aortic valve VTI. What is aortic valve VTI in this patient is?
58.1.
Divide by 58.1. What is that value is? 0.39.
0.39.
Correct. This is dimensionless index. Now look carefully. What you have seen in this patient, the aortic valve area is less than 1. The gradients are low and the dimensionless index is also more than 0.25. So what we are dealing with? We are dealing with discrepancies. That's what I was trying to emphasize.
Yes, sir.
And if we are dealing with discrepancies, now we shift over to other side to look at the slide. What could be the other ways of looking at these discrepancies? So what we do? My LV function is normal. So I can go to do a transesophageal echo to do a planimetry of the aortic valve. Dobertomy echo we only do when we have a low ejection fractions. We can do a cardiac cath, or we can do a global longitudinal stain, whether the stain is less than -19, less than 20. Because if my heart starts failing down, the gradients will change dramatically. And the next is we can do a calcium scoring. I did not touch these topics deliberately. What we do is like, just let me show
Okay,
you
sir.
now the figures. We do dobutamine echo in poor LV systolic functions. When we give a low dose dobutamine, the gradients as well as the area, the gradients will go up, the area will go down. It means we are dealing with true severe aortic stenosis. If the gradient goes up as well as the area goes up, it means we are dealing with pseudo-severe aortic stenosis. That's when LV function is poor. Now the next thing is we do a GLS. This is global longitudinal stain. It tells you about subclinical LV dysfunction. And look at this patient, the GLS is -17 in this subject. I hope it's -17, not seen over here. It is 17. The GLS is low in this patient. It has to be -20. Many people have a many cutoff, -18, -20. The lower the GLS, worse is the prognosis. So the patient has got a poor GLS despite good looking LV systolic functions. And third thing is we look at the calcium scoring by coronary calcium scorings. And when we look at a coronary calcium scoring, if it's more than 1400s, then we talk about severe aortic stenosis. So that's what exactly I said. Look, looking at aortic stenosis may look as normal, but when we calculate all the parameters, it found to be different. Your question was dimensional index, very simple LVOT
Yes,
divided
sir.
by aortic LVT.
Yes. Thank you, sir.
Anybody, any other questions? You have to go and read this, listen to this. Look, it's a very important thing is you can listen to this as many number of time as possible. This is not a difficult thing at all for you. And day you will make a severe aortic stenosis, poor normal LV systolic function, and your colleague tells you, look, you did a wonderful job. And that'll be the real happiest day of the life, you know. Roll number 26.
Sir, good evening, sir. I'm Dr. Swami, sir.
Yeah, Dr. Swami, Telangana, Jadd Cherala. So
Yes, sir.
go ahead.
Sir, where we want to keep the Doppler flow in LVOT VTI and aortic valve VTI, sir.
LVOT VTI will keep a Doppler flow at the level of just before the aortic valves. Let me show you a picture. This is not, I'm telling you, like, picture is a representative. So if I have to keep my LVOT, my flow pulse wave Doppler spectrum would be here. Correct?
Okay, sir.
If I have to calculate aortic valve, the pulse wave Doppler spectrum would be here. But when you have aortic stenosis, what will happen? Once you keep a pulse wave Doppler spectrum pattern over here, aliasing will happen, and that aliasing will not be contained by a pulse wave Doppler. Then you have to switch over to continuous wave Doppler.
Continuous.
So obviously, if your severe aortic stenosis is there, you have to switch over to continuous wave Doppler. So we do not do like do a pulse wave. At your level, you can pulse wave over here for LVOT, pulse wave over here for aortic valve, and when the Doppler spectrum pattern cannot be contained, switch over to continuous wave Doppler to get whatever I showed you. Look, this is what I already showed you. The Doppler flow pattern to across continent. And in machine, those people are not using it. If you look at one line, it means we are using continuous wave Doppler. When we are using two lines, it means using a pulse wave Doppler. Believe my words, it's a very tricky department of aortic stenosis. And when we have a look, we do a lot of work, no doubt about it. But our work is not like we are doing 100 echoes every day. Our average work of echo is about 15 to 20 echoes per day. But once we do a stress echo, like aortic stenosis, believe my words, I tell the patient, sit down coolly. Let me finish up my routine work. And then I'll start re-examining again. Because I'm not in a hurry. I have to take all parameters. And if you allow me, like I'll show you what is my, let me stop sharing over here. Give me a second. No, it cannot. Just give me a second. I'll show you like what all parameters we'll be doing in these Doppler flow patterns. Just a minute. And something is left. The patient is being called back again. No, sir, something is left. We have to come back again. It's not like that we are just doing it for the sake of echo that we have been doing echo. Echo means we are giving the final conclusive answer. Look, this is what is my diagnosis is. Give me a second. I'll show you like my formats of aortic stenosis. And these that do not remain the same all the times. They'll keep on changing all the times. Every new things happen that get incorporated in these formats. I'm just looking for a format. Give me a second because functions, prostatic, myocardial, major findings, arch of aorta. Yeah. So let me share you the formats. Just give me a second. Can you see my slides
Not yet, sir.
now?
Yes, sir.
All right. Now look, what is this format is? It's telling you, let me make it a little bigger. Correct. So this format is telling you about everything. Elaborate format. It has done measurements in all formats. Aorta, LA, LA, EDD, end diastolic, men and women, aortic valve, excursion. Forget about this. Now look at this aortic valve findings. Aorta diameter in diastolic. Thickened calcified aortic valve leaflet with restriction of cusp motion, valvular calcification present, aliasing at aortic flow velocity, increased flow velocity and gradients, peak velocity, mean velocity, peak gradient, mean velocity gradient at what window? Then what is the heart rate? What is the Nyquist limit? Aortic valve VTI, LVOT diameter, LVOT VTI, aortic valve area by continuity equations, index area, dimensionless index, and this I have not taught you like acceleration time versus ejection time, but stroke volume like 81 cc per beat and 45 cc per meter square per beat. Transvalvular flow rate I have not taught you. Cardiac output, GLS, above parameters are suggestive of high flow, high gradient severe aortic stenosis. And we took up this patient for a stress. Don't do it. It's not meant for you. We want to look for symptom-related exercise test. And these patients, when they was put on a stress, look, his gradients went up dramatically. So the mean gradient and peak gradient, they improves the like things. And that's how we decide. And we have put on all windows, 5 chamber, 3 chamber, right present suppressant and right anterior oblique view. And we'll try to take the maximum of those windows. And this really needs time, it's not like just you do it and forget about it. So that's how we do this severe aortic stenosis or aortic stenosis for that matter. All right, let's come down to questions again. Dr. Kamal Malviya, 21.
Ji, sir. Uh, is there any effect of hypertension on the aortic wall in the
Excellent,
calculation?
Kamal. I'm sure like you have done a very good job. You tell me
Thank
what
you,
will
sir.
happen with the hypertension to these people of aortic stenosis?
Mm, I
You
think
will overestimate
gradient
aortic
will get
stenosis.
affected. Gradient will get affected.
Yeah, gradient will be more.
It will reduce.
Pardon?
It will reduce.
Gradient will become more while they'll reduce. If the forceful ejection period is, no, I'm sorry, you are correct. The gradient will be, after load is more, the gradient would be underestimated.
Oh. So is there any way to do we go
Oh,
through it usually or not?
oh, when we see, look, I did not show you deliberately, but we always take a blood pressure when we're doing this aortic stenosis evaluations. And then we talk about the second and third step, not at your level, but let me just show you a couple things what we do in these subset of populations. No, not this. So give me a second. I'll just have to stop. These slides have gone, so I have to bring them back. Very good questions. I'm happy that you asked this question. But this is level 2, level 3. When we talk of advances, then we talk of all these things. Many things are there, not this is. We look at many other things when we talk of aortic stenosis like this. Anyway. So we are almost back, and let me share my slides with you. Make it bigger. All right. You can see the slides now?
Yes.
All right. When we have this kind of a problem, my blood pressure is high. What we do is we look at valvular arterial impedance. And what is this valvular arterial impedance is we calculate certain important tissue measurements. Like we talk of this impedance, this is JIT-VA, which is a left ventricular systolic pressure divided by stroke volume indexed. Or we have mean gradient plus mean arterial pressures divided by stroke volume index. So for you is LV systolic pressure, whatever you have calculated by blood pressure, divided by stroke volume index, you get this valvular arterial impedance. And this is true, like whatever you said is, if it's more than 4.5, again we talk of a severe aortic stenosis. But we do not do in every subject. If you are getting a good gradients, if you're getting a good flow, then we are not going to do it. Whenever we try to have underestimated gradients, then certainly this is a modality which we always employ in talking people with a severe aortic stenosis. So maybe like if you are interested, like you can just click a photograph, LV systolic pressure. That is what is seen in your blood pressure divided by stroke volume index. That you want to know how to calculate it. Okay. Lot of things are there. Let's not get into all these at the same time. But because too much to read it and that confuses not the answers. All right, let's go to the next person. Roll number 5.
Good evening,
Dr.
sir.
Debangna Adhikari from West Bengal.
Good evening, sir.
Good evening.
Sir, you said that we have to look at all the 6 windows.
Correct.
But sir, suppose we don't know if a patient has come to us and we don't know the patient has aortic stenosis. So do we have to look at all the 6 windows for every patient?
No. Why we look, what is important thing in aortic stenosis is when you have a leaf valve which is thickened, has got a high gradients. And second important thing which is applicable in 99% of subjects, these people have a left ventricular hypertrophy. Although I've got a patient who does not have a left ventricular hypertrophy but severe aortic stenosis is present. Not in every subject. If my flow velocity is only 2 meters per second, while I try to do all these things, when I look my flow velocity is about approximately 4 meters, 3 to 4 meters per 3 to 4 meters per second, then I start looking at all these kind of things.
But sir, that flow velocity also we are assessing in only one window.
Yeah, that point is good. But suppose we are utilizing not one, we are utilizing 3 and 5 chamber window views.
Yes.
Correct? So index of suspicion should be high.
Right.
I
Okay.
showed you a clip. Just give me a second. Now you tell me whether this person is going to have a severe aortic stenosis or not. Your eyes should be open all the time, you know. Do you expect aortic stenosis in this patient? Let me make it more clear for you. In our lab, we'll try to take blood pressure in as many number of patients as possible.
Hmm.
Now,
Sir, I don't see a doming here, and
we don't see a
even
doming. Doming may not be possible because doming is majority of time is there, but when you have a calcium, you may not see a doming. But the important thing is we do not see a very good LV hypertrophy.
yes, sir.
And Dr. Debagna, the most important thing is we should always have an stat along with you. Always.
Hmm.
We
Yes,
do
sir.
not see any significant things over here. And if it's a stenotic lesion, put a color flow across it. You'll show you turbulence.
Hmm.
So my quest is, like, if you have a velocity of 2.53 meters per second, just measure it, but calculate your aortic valve area always. If your aortic valve area is less than 1 centimeter square, then you spend time with the patient looking at all windows. Let's take in that fashion,
Okay. Okay, sir. Understood.
right?
Yes, sir. Thank you, sir.
Thank you. You don't have to pay thank you to me at all. My thank you is when you get a certificate, when you do something good in your area, and when people ask you, where did you learn all these things? That'll be the thank you I'll ever have in my life. People should come back and tell me, look, Dr. Debagna is doing excellently well. That is what we need to have. Thank you from you. All right.
Yes, sir.
So let's go ahead. Anybody else? Before I switch on my slides for pulmonic stenosis. Not a large topic, it's a small topic. Not as big as aortic stenosis. I roughly take about 40-45 minutes, maybe more, to do my aortic stenosis, as I told you a few minutes back. All right. So let's switch over. Dr. Shikha Jain, your mic is on. You want to ask something? Or you can switch off your mic.
Sir, what is the normal aortic valve area? This.
Anything more than 2.5 to 4 centimeters square.
Okay, sir. Thank you.
Dr. Gaurav?
So good evening, sir. Sir, I just wanted to know the severity of aortic stenosis. In some there are like mild, moderate, and severe. So, according to sir, any other parameter we can
Look, many
other than
people they
EVA.
came up like what they were saying. Less than 1 is severe, 1
Sir.
to 2.5 is moderate, more than 2.5 is mild. But when we talk of aortic stenosis, I think in a different fashion. I say whether it is interventionable or non-interventionable. Interventionable means when it's less than 1, non means when it's more than 1. And that's why the nomenclature changed over a period of time. This is severe versus non-severe or progressive.
Okay, sir. Sir, can we tell this mild, moderate, severe according to peak gradient and mean gradient, like
No,
less than 40?
no, no.
We should not. Okay.
I told you the same thing. If you say that peak and mean gradient is like, suppose your aortic valve area by continuity equation is less than 1, your gradients are normal. What are you
Yes,
going
sir.
to say then?
Yes, sir.
So, whatever I taught you last 1.5 hours, it looks like it's a like lot of exorbitant things. Believe my words, what you need to do is you have to calculate the alveolar diameter, go to
Yes,
3
sir.
chamber view, look at a pulse wave Doppler spectrum, trace it, do a continuous wave Doppler spectrum, trace it. That's all 3 findings. And look at ejection fraction. Even if we don't calculate ejection fraction, by naked eye also you can say normal or abnormal.
Yes, sir.
Then you are done.
Right, sir.
And majority of times when we have a severe aortic stenosis, the picture itself will tell you that we are having a severe aortic stenosis.
Yes.
So it's like doing it. It's like looking at it. And believe my words, we also make mistakes number of times, even today also. Because when we are hurry, I see a gradient of only 25 mean and peak is not much. I say is a progressive. And when we do a complete evaluation, I said day before yesterday, that patient was having bicuspid aortic valve with a gradient of more than 54 mean gradient. We did everything and it was carrying a severe aortic stenosis. Unfortunately, nobody looked at the right parascender window. If I would have been in a hurry, I would not have, even I would have left if I'm not doing it correctly or thoughtfully. And the referring physician was very strong. He said, Dr. Gupta, this patient has got, if you put a hand on his chest, an apical window, you can feel a thrill. You can feel the apex beat. And the patient had got a classical 1 AVL V5 V6 T wave inversion, inverted comma shape. And he says that this patient is definitely going to have LVH and severe aortic stenosis. That is a clinical person who's about 74 years now in his age, maybe more. Dr. Sudhir Oswal in Delhi. Very intelligent person. Those are the time when the clinicians used to make a diagnosis. We are foolish people, you know. Those people used to make diagnosis and we used to prove it. That's all. Now we give a diagnosis and a clinician tries to treat it. And
Yes,
there's
sir.
no match for clinical examinations.
Mm.
We
Yes.
often get a patient of severe aortic regurgitation. You know what is the blood pressure? 120/80. Diagnosis severe aortic regurgitations because they just look at the aortic regurgitation and they say severe. How can you have a severe aortic regurgitation with a BP of 120/80? You have to have a real wide pulse pressures.
Pulse pressure. Yes.
If you remember, I don't know whether your boss ever told you or not, like you used to raise your hands, feel the pulse, it's a collapsing pulse. When I did my MD in 84 from Agra Medical College, we hardly had any echo. And whenever the boss used to get a patient of aortic stenosis, aortic regurgitations, I still remember they used to tell us, let the patient stand, hold his hand, look at his pulse, and tell me what kind of pulse it is. And I still remember like stalwarts of medicine in Agra Medical College, Dr. Ram Singh, Dr. P.K. Wal, Dr. M.C. Gupta, Dr. Hajra, Dr. M.M. Singh, Dr. Brij Kishore. 6 units and they were real stalwarts, you know. Dr. P.K. Wal got 13 PG, 13 cases of mitral valve prolapse syndrome in one day in GCR, Grand Clinical Rounds. And there was a mid-systolic click in every one of them. 13 patients, 13 PG, 13 MVPS. And majority of them, they were marfanoids. And 13 PGs means 36 diagnoses. And then every patient was doing Utthak Beta to look for a mid-systolic.
Yes, sir.
So that was clinical examinations. Today is not a clinical examination. I often see my colleagues doing a cardiology OPD without a stent in the blood pressure. Chest pain, ECG, echo, maximum tropi. So if you want to really take home messages, please look at the patient, spend time, few minutes with him, look at an ECG, look at an X-ray chest. These two things are not going to go away at any time of your life. All right. Dr. Shabir, go ahead, Dr. Shabir, before we move on. It's almost 11:15. Many
Sir,
people
good evening, sir.
cursing me.
Sir.
Look, we are talking all bullshit now. Roll number 20. Shabir, go ahead.
Sir, good evening, sir.
Good evening.
Sir, you have shown a slide with severe aortic stenosis. In that, it is mentioned that normal ejection fraction of more than 54% something. So, does it mean that having a normal ejection fraction in a patient with aortic stenosis indicates higher severity, sir?
No. I wanted
What
to
does it
say
mean?
that when I'm showing you ejection fraction, it means it's a concept as on today. If you really ask me 54% ejection fraction, if I'm showing you, does it mean by normal ejection fraction? Yes. If you go by literature, if you go by guidelines, this is normal ejection fraction. But this is what slide you're talking about, right? Now the question is, when we have a left ventricular hypertrophy, my ejection fraction will go up dramatically. When the ejection fraction starts falling down, it could be normal, maybe more than 52 or 54.
Okay.
So if the ejection fraction is normal, if you really ask me, if I got a left ventricular like severe aortic stenosis with low ejection fraction, I call it low. There was an article published in JACC in 2019. There was a full volume of Journal of American College of Cardiology on aortic stenosis that recommended a normal ejection fraction for AS is 58-59%.
Okay.
So if I happen to see this 54% ejection fraction, I always calculate, believe my words, when I see my ejection fractions in aortic stenosis. I'll virtually calculate what I show you, like how to calculate it.
Okay.
If I find my ejection fraction to be like 54%, 55%, 56%, I understand this patient has already gone into subclinical LV dysfunction. I may be underestimating his gradients.
Okay, sir.
All right.
Yes.
So this is how we work. At your level, even if you diagnose severe aortic stenosis, I think that's more than enough for you.
Okay, sir.
Because once you diagnose, obviously you are going to refer that patient to somebody for further evaluations. If you miss, that will be wrong.
Okay, sir.
Okay?
Sir,
All right.
one more question, sir.
Go ahead. Go ahead.
Sir, we usually calculate indexed values, correct, sir? So,
Index value of what?
for most of the things, sir, as you said, it is very important to calculate indexed
Correct.
values. But my question is, sir, so are we generally incorporating body surface area? Because we don't generally see in our hospitals, and most of the hospitals, is it true, or
Shabir,
is the practice different in North India, sir?
No, nothing is North India is different. North India is as good, as bad as South India. And they are more horrible than South India, I can tell you that. The problem is, nobody has got a time to put in a leads and put in a height and weight into the machine.
Okay, sir.
I'll share a very important thing. One of the person, Mark Anderson, who was a G, like CEO of a G, came to India at one time. And he went to GB Pant Hospital in Delhi, the tertiary care cardiac center.
Okay, sir.
You know, when he came out of the GB Pant, he said, he went to the echo lab. He said, I don't think it's a echo lab. It's a postal stamp department. I said, what happened? He said, patient was lying on a table. The guy will put a probe and he'll come out. So it's like, he said, like, it's just postal stamp department. The patient will lie, put a probe, out, next.
Understood, sir.
So It's not his problem. The problem is the volume of patients
Volume.
which comes in.
Understood.
I went to Calcutta. I'll not name of a hospital. 110 people of echo every day. I said, you're crazy. You're crazy. How can you do 110 cases every day? If I'm doing 25 to 30 cases in one day, believe my words, I'm dropped dead by evening. I
Yes.
often leave my reports and come back and go back in the morning on that day, next day, to complete those reports. Normal reports I'll release. Rest of the reports I'll hold for next day.
Okay, sir. Understood. Thank you so much.
All right. So let's move on. Roll number online, repeated one. Somebody want to ask it? This is Dr. Chaitanya. You want to ask something more? Or are we done? All right. So let me stop sharing my slides over here and switch on to pulmonic stenosis. So I'll stop sharing and now let me get to pulmonic stenosis. All right. Now you can see the slides.
Yes, sir.
Now remember, this is a very valid question, normal asked number of times, and you will always make a mistake. When we see pulmonic valve, this is the most important window where we'll see a pulmonic valve. This is not pulmonic, this is the pulmonic valve. And we often see only two leaflets. One is anterior, second is left leaflet. So whenever somebody asks you, like, this is what anterior and left leaflet are seen, and many people, they ask you, when we talk of pulmonic regurg, I'll show you which leaflet is majority of time is torn, especially after TOF repair. Now, same as aortic stenosis, we have a suprapulmonic stenosis, subpulmonic stenosis, and pulmonic stenosis per se. What does it mean by? If I look at this slide, this is aorta and this is pulmonic artery. It arises from right ventricle. If you have a lesion at the level of pulmonic valve, that is pulmonic stenosis. If the lesion is distal to pulmonic valve, this is suprapulmonic, and it's below than that, it's an RVOT. Then we call them as subpulmonic stenosis. Now look carefully. This is aortic valve. This is my pulmonic valve. And where do you see a stenosis? Stenosis is seen over here in RVOT. It has been divided by muscle band to proximal RVOT and distal RVOT. It may not look good with 2 dimensions echo, but as soon as I see 3 dimensions echo, not at your level again, I can see a muscle mass over here. And when we switch on the colors, we immediately see a turbulence at this level of subpulmonary. Look, there's two lines are there. This is site specific. And we see turbulence at the subpulmonic levels. I'll show you a case, like, which was very interesting. After that, here's a valve. Now stenosis is seen over here. That is suprapulmonic stenosis. So how do we really get to a pulmonic, suprapulmonic, or subpulmonic stenosis? By utilizing our pulse wave Doppler. What I'll do, I'll put my pulse wave Doppler at the pulmonic levels, then go back to the subpulmonic level or go forward in the suprapulmonic level. And whenever I start seeing aliasing, that is the place I have a stenosis. So here's a pulmonic valve, here's a suprapulmonic stenosis. Now, very clear. Now look very carefully. The turbulence is seen over here also. but the majority of turbulence is seen over. There's a band of muscle mass distal to pulmonic valve, and there's a lot of turbulence over here. If you put a pulsative Doppler pattern, your velocity may be 1.2, 1.5, but here the velocity is very high. And this velocity is almost 3.9 meters, 64 millimeters of mercury. Anything more than 3 is considered as stenotic levels. Now, same another patient, look at the turbulence at the level of pulmonic valve and look at the jet where it's striking back. This is left leaflet, this is left anterior leaflet, this is, sorry, left leaflet and anterior leaflet. So in stenosis is virtually at the just below the left leaflet. Sorry, I'm saying a wrong word. It should be anterior and left. Yeah. Stenosis is just behind the anterior leaflet. And there is turbulence seen over here, but the turbulence is maximum over here. The gradient is 3.18 when I'm using a pulse wave and continuous wave Doppler. So not a rocket science. Severe pulmonic stenosis majority of time is associated with other issues like VSD with PS, normally congenital. Then second, carcinoid. They are one kind of a tumor which originate from intestine, leads to involvement of tricuspid and pulmonic valves lesions. Then what we look at anatomy, thickening, valve hemodynamics, valve consequences of these hemodynamics and symptoms. So what is anatomy? Thickened, distorted, possibly calcified leaflet, anterior and versus left, with doming with reduced excursion. But the important thing is, we look at a pulse wave and continuous wave Doppler, the gradients are more than 4 meters per second and 64 millimeters of mercury to consider them a severe aortic stenosis. Same as we have aortic stenosis, we can have a right ventricular hypertrophy. RVRA enlargement is a very late stage of when RV starts failing, you start having RVRA enlargements. And it's a known fact, whenever we have a severe pulmonic stenosis, the main pulmonic artery distal to the lesion starts getting dilated. And what we know is normal diameter of a pulmonic artery is about 26 millimeters in size. And this post-stenotic dilatation starts happening. Now, in newborn, what we see is the pulmonic artery bifurcates into left and right. This is right, this is left. And you may find a turbulence in peripheral pulmonic artery stenosis, which could be a normal phenomena in a newborns. Why it happens? Like if you think over it, my pulmonic arteries are virtually rudimentary during my neonatal infantile periods because not much of a blood flow is going to the lungs because they were not working. As soon as the neonate or child starts breathing, the lung expands and there's a lot of flow of blood happens to the pulmonic arteries. So pulmonic artery needs time to adjust to that large amount of blood. And the best example you can get is just take a bucket of water, put in your sink. You'll find the murmur or sound of the water getting through that exit or a hole. The same thing happened. That's what we hear in a pulmonic souffle in newborns. And that's over a period of time disappears. So this is one example of pulmonic souffle, a testing of pulmonic artery in the right pulmonic artery. So we pick a pulse wave Doppler spectrum at right main pulmonic artery, left pulmonic artery and right pulmonic artery, and we find that right pulmonic artery velocity is very high. Look at the pulse wave Doppler spectrum, 2.62 is the right pulmonic artery. So how to assess? Always short axis view at aorta to look for a site of obstruction like distal, proximal or valvular. Then put a sample volume at the site of turbulence. Suppose my turbulence is at the level of valves, first valves, pulse wave. Look at the Doppler spectrum pattern. Move the line up to see how much is the velocity. No turbulence, not increase of velocity. Normal velocity is up to 1 meter per second. Then I move my cursor distal to this obstruction. Turbulence, this is aliasing, turbulence, and when the Doppler spectrum pattern aliasing starts happening, then you switch over to continuous wave Doppler. It will contain a Doppler flow pattern of pulmonic as well as obstruction. That's what we call as suprapulmonic stenosis. Now look at this Doppler spectrum pattern very carefully, if you can look at it. They look at two Doppler spectrum pattern in this. One is over here and second is over here. One is over here in this spectrum also. The second Doppler spectrum pattern is coming all the way down. So this is a Doppler spectrum pattern of the valve, and this is a Doppler spectrum pattern of the suprapulmonic stenosis. These are the guidelines, AHA 2014 guidelines. Severe PS, thickened, distorted, possibly calcified leaflet is systolic doming with reduced excursion. Other anatomical abnormality may be present, such like narrowed RVOT that become proximal RVOT obstruction. 4, velocity, 64, peak gradient. We are not talking of mean gradient in this. Proximally, you can have a right ventricular hypertrophy. You may have a RVRA which will dilate over a period of time, and you have a post-stenotic pulmonary artery dilatation. That's it. So, questions. I'm sure everybody must be tired and hungry by now, but I'm not going to leave you till we complete this work. So, questions, let's raise your hand and solve the questions. Very simple. Pulmonic is not a rocket science, not a difficult subject at all. Important subject is, and most important thing is, why we'll get a pulmonic stenosis unnecessary. It's a very rare to get a pulmonic stenosis. Unless until a patient have operated TOF or you got a VSD with PS, you're not going to get easily the pulmonic stenosis. Normal, even atherosclerotic process does not affect much to pulmonic valves. Very strange phenomena. You may see a lot of atherosclerotic mitral valve. You may see a lot of atherosclerotic aortic valve. But recently we saw one more patient of atherosclerotic pulmonic valve also. And then I started looking for other causes of atherosclerotic valve, like whether this patient has got RV hypertrophy or pulmonic tricuspid valve involvement. Nothing was there. So no questions. Everybody happy? All right. Everybody is not happy, man, nowadays. So I'll stop my sharing my slide over here.